अस्सलाम वालेकुम you guys.
वालेकुम अस्सलाम रमीना। अच्छा यार, उसका कोई मसला नहीं। एक मिनट में रिकॉर्डिंग पॉज करूँ।
क्या?
हो गया। ठीक
अच्छा
है,
ठीक
मैं
है.
वापस बंद कर रही हूँ।
चलें, ठीक है।
Okay. So
All right. So, Assalamu alaikum, everybody. Thank you all for having me, especially Pakistan Association of Dental Students. It's my second webinar with them. The first face-to-face one. The first one I had with them was I think, in the immediate period following COVID. Unfortunately, during that time, our schedules did not align properly, so I only conducted a recording of a webinar with them. So this time I'm hoping to have a more interactive discussion and interaction with you, all of you. And like I tell all my students in my undergraduate class that I hope you all feel free to ask any sort of question, no matter how idiotic you think it is or how simple you think it is. I warmly encourage all of you to please do feel free in asking questions. Do put them up in the chat box, and inshallah, I'll try to run by all of them one by one. So just a slight addendum to Rumina's introduction of me. I have not completed yet my master's in health research. I'm still a student of master's in health research. So just wanted to put that disclaimer out there first. So anyhow, I'm very grateful to Rumina and the PADS Association for volunteering me or selecting me for delivering this talk. Originally, the talk was about management of head and neck cancer, but I think given the scope of my audience, I think it's much more pertinent that you know how to recognize oral cancer in your setting and how to manage it, being a general dental practitioner, because a lot of you are dental students right now. Some of you may be dentists right now, but probably I'm not in my audience. I don't think there are any specialists over here. So I think talking at the specialist level will just probably go over the top of your head, and that's not something I wanted. So my talk will be focused on how to recognize oral cancer in a general practice and what you can do to help manage it, inshallah. So the contents of my presentation are as follows. First of all, I'll talk a little bit about what is oral cancer, what causes it, what is the importance of recognizing oral cancer, in which I'll be sharing a few articles with you, and we're going to run through a bit of those. Then I'll also be briefly talking about the concepts of professional and patient delay in recognizing and managing oral cancer. Then how to recognize oral cancer specifically, and lastly, what can you do at your level right now. So I'm not sure how many of you are aware of oral cancer or the origin of the word cancer. It basically arises from a Greek word called karkinos, which actually means crab, or how, like I'm sure you know all your horoscopes. So the sign for the cancer sign is a crab. So originally in ancient Greek, this name was given based on the appearance of the feeding vessels of the cancer, and they thought that this resembled the limbs of a crab. So the origin of the word actually arose from over there. This picture, in a way, is also a good representation of how oral cancer treats somebody once it enters that unfortunate person's life. that once it takes hold of you, unfortunately, it rarely lets go of you for the rest of your life. So I'm sure you've all gone through bookish definitions of oral cancer. So I'm not going to go through a bookish definition of oral cancer with you. I believe that genius lies in simplicity, and the best definition of oral cancer that I found was that oral cancer appears as a growth or an ulcer in the mouth that simply does not go away. So I think if you focus on the text highlighted in yellow, I think that will give you a very good idea of how to recognize this lesion once you come across it in your general practice. No matter what sort of medications you give, what sort of dental treatment you give for it, it simply does not go away, or it may go away for a little bit of time, but usually it has a very bad habit of coming back, recurring and re-entering that person's life. And ultimately, I won't say most of the cases, but in a lot of cases, it does end up taking that patient's life. So it can affect any region from the lips to the back of the oral cavity. No specific one area of the oral cavity is spared from this pathology. So you have to look for it everywhere. And this is what I'll be discussing briefly in the process of how you will examine or screen a patient for oral cancer, and how you will have to tell the patient to do self-examination. So we'll talk about that basically later. Coming to the epidemiology of it, the Global Cancer Observatory is one of the few banks throughout the world which documents cases as per different countries. And the statistics that they posted related to Pakistan was that oral cancer is the most commonly diagnosed cancer amongst males in Pakistan. So over 11,000 new cases per year are diagnosed in males, and it is the second most common cancer diagnosed in females. It's more than 5,000 new cases per year. These statistics are of the year 2020. Any statistics more recent than that, unfortunately, are currently not available. Maybe in a couple of years' time, we'll have the statistics for 2023. But this should give you a very good idea about the burden of oral cancer presently in the country. So overall, it is the second most common cancer diagnosed in Pakistan, with over 22,000 new cases every year. So just to put all of this information in context, this is the table that I've taken from their fact sheets. If you just go into Google and you write Global Cancer Observatory Pakistan, so a report will come up. I think will be probably the first link that you come up with. And this is I've taken from that report. So you can see that breast cancer is the most common cancer in Pakistan, over 14.5% of cases. And following that is lip and oral cavity. And lung cancer, esophageal cancer, colorectal cancer, all are below that. And all the other cancers, which are not being specific for any specific subtype, they make up around about maybe 60%. So 14.5% or 10% of almost all cases, these are very, very large numbers. So this should give you a good idea about the burden of the disease present in the country. So what causes it? Well, I'm sure you would have studied this in your third year. If you're not in your third year, soon you will study it. And people who are in final year or who are currently in their house job, they would have had a fair idea about it. So I'll just go through it superficially without going into much details. The first and foremost culprit is obviously the use of tobacco. So tobacco you can use in different forms: smoked forms, smokeless forms. So it's amongst the most common reasons for patients developing oral cancer. Now, tobacco, along with its synergistic relationship with alcohol, is also a very big part of why patients develop oral cancer. Now, you may think that, Pakistan being an Islamic country, you won't have a level of consumption of alcohol that is seen in maybe in the Western world. But I'm sure any of you who have seen those investigative journalism shows on various TV channels, you would find out that a lot of the times they do episodes on which they have, raided a factory which was making substandard alcohol and distributing it throughout various regions via open market or via the black market. So you can't ignore the role that alcohol does potentially play in the development of oral cancer in Pakistan. However, another one thing that you would see very openly is obviously the use of Naswar. So smokeless tobacco is unfortunately as commonly is, I would say, it's a more of a socially acceptable drug than the use of tobacco or alcohol. And just because of its wide social acceptability, unfortunately, a lot of patients keep on using it, and they only stop once they get a really advanced form of oral cancer. So I have a very funny story actually to share about the use of Naswar. We had, I think, Eid, Badi Eid at our house a couple of years ago. So one of the kasabs, he was cutting the meat into different pieces, and I think he lost his focus and something, or he was chatting with the other men. So during that time, accidentally he cut his finger with one of his very huge knives. So he unfortunately started bleeding. He was in a lot of pain. So at that time, I think I was inside the house. So one of my cousins came up running to me that, Fahd bhai, please just come on outside. The guy has cut himself and he's bleeding a lot. So I immediately went down and went up to check on him. And I asked him to show me his wound so I can see if it's superficial or has he cut himself very deep. We might have to take him to the hospital. So once I was removing the cotton and whatnot, when I was checking his wound, I saw some very green type of material coming out of his cut in his finger. And I was like, what is this? It wasn't making any sense to me. And I asked him, okay, have you put anything in your finger? So the leader of those kasabs, he said, yes, sir, I've put Naswar inside his fingers to help alleviate his pain. So I was shocked beyond words. I was like, who told you that Naswar will reduce pain in case of a cut? He said, sir, it works very well in the mouth, so I thought it will work very nicely in his finger as well. So that should tell you a lot about how people are grossly unaware about the lack of good qualities, or I would say the disadvantages or the harm of using Naswar. So anyhow, that was a funny anecdote, and I thought I'll share that with you. All right. So moving on ahead, a specific type of viral infection is also known to cause oral cancer. You might have heard of the term human papilloma virus. So two subtypes of the human papilloma virus are known to cause oral cancer as well. HPV was commonly thought to be only associated with oropharyngeal cancers or throat cancers, but latest research does show that prolonged exposure or having such type of a viral infection can predispose that area to the development of oral cancer later in that area. Now, you might think, what does sunlight have to do with all of this? Well, cancer of the lip, specifically the exposed part of your lip, your dry lip, if there is excessive exposure to UV light, so there is a high chance that you can develop oral cancer of the lip as well. So use of sunblock is quite highly recommended in a lot of research articles when it comes to protecting yourself against developing oral cancer of the skin and specifically of the lip. So yes, exactly, UV rays. Now, lastly, I would say that there is an element of fate, of destiny as well in the development of oral cancer. Again, I'll share an anecdote. One of our chemistry teachers, he used to smoke, I think, about for the last 30, 40 years. By the time he came to teach us, he was in his late 60s, I would say maybe even early 70s. So at that time, when we were studying, and in our A levels or in our O levels. So when we first studied about the harmful effects of tobacco and alcohol, so we used to tell him, sir, that why are you smoking? Like you know chemistry, you know what are carcinogens and what role they can potentially play in the development of oral cancer. So he said, I've smoked for the last 30, 40 years and nothing has happened to me. So I'm fine, So it's all this talk about tobacco, I just don't believe it. So you will probably have come across some people or heard about some people who may have never smoked a single cigarette in their life, yet they do develop cancer. So that actually tells you that as much as environmental factors play a role in the development of cancer, your genes have also a huge role to play in the development of cancer, regardless of how much environmental exposure you may or may not have received. So a lot of you might have heard about the cytochrome P450 system inside your body. Instead of going into the details of it, the simplest way I can explain cytochrome P450 to you is that, let's suppose you have a neighborhood, all right, and there is a thief in that neighborhood. If a thief comes and in that neighborhood, the police is doing their patrols and making sure that every area is well covered and you're not seeing any suspicious people. So let's suppose that thief is planning on robbing a house, and at that time the police just happen to come across that street. So what will the police do? They will arrest the thief. That seems very obvious. Now that is the same role that cytochrome P450 does. Your cells are dividing and they are reproducing and making new cells. New DNA codes are being established. So P450 checks and repeatedly checks that has anything out of the ordinary been happening, or has any sort of wrong DNA code or an abnormal type of cell has not been made. If such a type of a cell has been made, so the cytochrome P450 is involved in inducing cell death of that specific area or destroying that DNA code. So if your police is not functioning properly, so what will happen? Your patrols will keep on happening inside that neighborhood, but that police will not be able to differentiate that whether this person is a thief or is this person simply someone who is going inside their own home. So once your police starts behaving like that, when it's not arresting the criminals, so obviously crime will start developing in that neighborhood. Once one criminal says, hey, police doesn't say anything to you, you should come on over here, this neighborhood is full of rich people, let's go and rob them and whatnot. So that will encourage further criminals to infiltrate that neighborhood and obviously make that neighborhood unsafe. So P450 is the police of the body. So once your police of the body is not functioning properly, so then that is where problems really start to happen. And that is what actually leads to the development of oral cancer. So other than that, you might have studied about precancerous lesions or pre-malignant lesions or pre-malignant disorders. So WHO actually replaced that terminology in 2006. Now they've grouped the lesions together and they call them potentially malignant disorders. So you might have heard of the terms leukoplakia, erythroplakia. These are the two pictures on top. This is leukoplakia over here. On the top right, this is erythroplakia. Anybody would like to guess what this lesion is? The one on which my cursor is at the moment? Anybody in the chat box? Remember, there are no right or wrong answers over here. This is not an exam. So if you want to just take a guess what this lesion could be. Yes, exactly. Very nice. So this is basically lichen planus. So lichen planus is also a potentially malignant disorder. It has a malignant transformation potential of less than 1%. But since you see lichen planus very commonly, or you will see it very commonly once you enter your private practice. So it is very important to keep such patients on follow-up and keep checking the lesion, whether, God forbid, it's showing any signs of malignant transformation or not. Now, for some of our friends here who might be from Karachi, diagnosing the last picture should not be very difficult for them. So anybody would like to take a pick at the last picture? what you see over there? Yes, very nice. So this is basically a case of oral submucous fibrosis. If you just pay attention to my cursor over here, here is that typical white fibrous bands that you see in the development of the cheek, which is synonymous with oral submucous fibrosis. So this is basically done by using pan, gutka, etc. And over time, it will lead to the development of such mucous bands, submucous bands in the oral cavity. It can affect the lip, even the posterior part of the palate, and it can also transform into squamous cell carcinoma over time. So briefly, that was all about what causes oral cancer. So coming to the next part of today's talk is what is the importance of recognition. So has anybody heard about staging of cancers or staging of tumors? Anybody? Yes, you can answer if the hosts will allow you to unmute yourself. You can tell me about if you know what is staging or if you've heard of staging. So, okay, we have a couple of people who say they've heard of staging, so good. Basically, staging is implying to you what is the present status of the disease. The higher the state of the disease, the worse usually the prognosis is, or it means the more widespread the disease is. So this was a study that was done in the center where I trained in Khyber College of Dentistry. One of my seniors did it, Dr. Sana Wazir, who's presently herself, she's a consultant in Lady Reading Hospital, Peshawar. So this was her FCPS thesis topic, that what are the common factors dealing the diagnosis of oral cancer. So you can see if you can't check out that what is the odd thing here. Now it should be very clear to you that the majority of the patients that we saw in our center, over 75% of them were in stage 4. So if I'm to give you a rough idea of how survival is as compared to stage, so if a patient comes to you in stage 1 or stage 2, meaning the disease is relatively well localized, it has not spread to the different parts of the oral cavity as well as to the neck or the rest of the body. So in those cases, you can have up to 90% of patients will live up to at least 5 years for stage 1 or stage 2. However, coming to stage 3 and 4, that survival rate, 5-year survival rate, drops down to about 30 to 40%. So that is almost half, even I would say even less than half. So the problem here in our population, in our patient population, is that 75% of patients are already coming in stage 4. If you combine stage 3 with it, that makes it almost 84% of our patients are coming in very late stages. So if they're coming to you in very late stages, that should tell you that probably they're not going to live for very long, or that their survival is already compromised before even you attempt to do any sort of treatment in such patients. So let me just show you a picture just to give you a context of what stage 1 and stage 4 looks like. So the top left picture that you see, this is of a typical stage 1 lesion, around about 1 centimeter, less than 2 centimeter in size. And there is usually no spread to the neck or the rest of the body. And here is a stage 4 lesion. If you pay attention, it almost looks like this lesion has involved the whole of the maxilla. So a lesion usually more than 4 centimeter in size, along with some other parameters as well. But since my audience is at an undergraduate level, so I won't go into the other parameters, but basically we do the staging somewhat based on size. There are other parameters as well. So just to give you a rough idea, most of our patients are actually coming in this form to us. So that should give you an idea why a lot of cancer patients unfortunately don't survive. So why are such patients coming in such a late time? Why are they coming in such a delayed stage to you? Well, here you should understand 2 concepts. The first concept is a patient delay, and the second is a professional delay. If you look at international literature, they classify delay as the time taken for the patient to report the onset of the symptoms till the time that they are biopsied for such a lesion, and then they get their biopsy report. So internationally, they expect that a patient with suspected oral cancerous lesion should report to a doctor, to a dentist, or a maxillofacial surgeon for their biopsies within 14 to 21 days of reporting such a lesion. The problem is that over here in Pakistan, especially 14 to 21 days, while patients are almost to the point of being non-existent. A lot of patients are coming at a very delayed stage. So what are those reasons? We're going to get into that. So if a patient is coming to a very late point, that let's suppose he had symptoms and then he waited around about 2 or 3 months and then he reported to you, this would come into patient delay. What would be a professional delay? Professional delay would be, let's suppose that a patient who had such symptoms, he noticed such a lesion, he went to a dentist. The dentist did not catch the fact that this could be a potentially malignant lesion. What he did, he just prescribed, let's suppose, antibiotics, or he, let's suppose, wrote topical steroids, and he sent the patient back home. Then that patient not being satisfied, let's suppose he went to someone else and someone else also did not catch that this could be potentially malignant. What they did, they changed the antibiotics, they prescribed a mouthwash, they changed the steroid, and they told him to use this for 1 month and then come back if then there is no problem. So what is the problem over here? The problem over here is the dentist is not recognizing that what I'm dealing with is potentially malignant. So that would count as professional delay. So we have something in the chat box. Let me see what people are saying. Yes, ignorance is a big reason too. Not many people take their lesions in the mouth seriously until it worsens with time. Exactly. This is a major reason for the patient delay, that they don't take it seriously until it develops into a very advanced form of the disease. So this study, again, I'm quoting my senior Dr. Sana Wazir's dissertation over here, that both dentists and patients were responsible for delay in over about 58% of cases. Patient delay was the second biggest culprit, and that was about 26% or almost 27%. So 27% of patient in cases, only the patient was at fault. In 14 or almost 15% cases, the doctor was at fault for not recognizing the lesion on time. And both were at fault at round about the 60% mark. So this should tell you that there are problems on both sides, on the patient side as well as the doctor side as well. So this is why stage 4 and stage 3 usually predominate amongst our patient population. So what are the reasons for that? There was a good study done by Dr. Kashif Ali Channar in Sindh, I think he did this study. So he wanted to see what were the major reasons why are patients coming with such a delayed presentation. So the first thing, and this I think the next speaker will probably be talking more in detail about it, why are patients unaware about oral cancer and what is the role of preventative dentistry or community dentistry in addressing this. So I will leave this talk to him. The second most common reason was the lack of availability of medical staff. Now, this is a patient-reported study, so these claims from the patients cannot be independently verified. However, the lack of awareness amongst our patients is predominant in about 51% of our population. So even if they have such a lesion, again, the patients do not suspect that what they have might be oral cancer. So the problem here again is double-edged. You have patients who are not aware about what they have, and then you potentially also have the lack of availability of doctors who can diagnose that lesion on time. So on average, in most cases of our patients, especially the patients reported a delay of more than 200 days in about 40% of cases. So that is a huge number. 200 days for us is maybe half a year, but for cancer, that is a lifetime. All right. So These are all the reasons why we are facing patients who are coming with such a late presentation and an advanced stage of oral cancer. So where do we fit in? Where is the dentist? And I'm not talking about a maxillofacial surgeon. I'm talking about you, the future dentists of tomorrow and the present dentists of today. So as you've heard a lot of, I'm sure, quotes, the first step is the hardest step. And that rings so true when it comes to diagnosing patients with cancer. Unless you have people who know how to recognize cancer, the rest of this journey cannot begin. Whenever a patient who is suspected of being having oral cancer, he needs to be screened. And if there is a high chance that what he has is potentially malignant or is potentially cancerous, he needs to be referred. So a biopsy can be done. If he's not biopsied, he's not diagnosed. If he's not diagnosed, he's not referred to a multidisciplinary team or a maxillofacial surgeon or to a specific cancer hospital. And none of these other steps happen. No investigation is done, no diagnosis is done, no treatment planning is done, no cancer treatment is done, no rehabilitation and restoration is done. And obviously, when none of these is done, then you can have no concept of survival. So the first step is the most important step. And this is what I'll try my best that I teach you today, that how do you screen and for oral cancer, and what can you do to facilitate referral of such patients. So those of you who are in final year or who have gone through final year and are currently in their house jobs or have gone through their house jobs. So this is a table that you would have come across while reading contemporary oral and maxillofacial surgery, which is considered to be a textbook for most institutions in Pakistan. So the chapter on principles of investigation of a malignant lesion, this is a table that will not leave you for the rest of your life. And if you remember this table, you can potentially save the lives of a lot of your patients. So which lesion should you suspect that this is potentially oral cancer? So any lesion that has grown rapidly for no obvious reason, all right? So you can say the same thing for an infectious lesion. Infection. If you have a patient with a facial space infection, facial swelling, they also show rapid growth within a couple of days. But for that, a reason is present, and the reason is your carious tooth, all right? A tooth which has now undergone pulp necrosis, and that tooth will develop facial swelling later on. So a cancerous lesion usually grows rapidly without any reason. So you might not see any carious tooth. And even if there is a carious tooth, you don't develop cancer from a carious tooth, all right? Secondly, if your lesion shows a reddish or a reddish-white appearance, all right? So that can also be oral cancer. A lesion which is firmly fixed or attached to your adjacent anatomic structures, and specifically a lesion which is in a high-risk area. So what are the high-risk areas for development of oral cancer? That is your floor of the mouth, the lateral borders of your tongue, and the retromolar area. So specifically, you see a lesion over here which looks like an ulcer, you should immediately raise your suspicion and think that this can be potentially a malignant lesion. In addition to that, sometimes you may have an ulcer in your mouth, which can be due to a defective restoration, a sharp tooth, a fractured tooth. So first of all, you have to address the cause. So whatever the cause is, let's suppose it was a sharp tooth. So you do smoothen the sharp cusp, or you do a filling, or if there is a fractured piece of the tooth, you remove that fractured piece. Or if your restoration is sharp, you smoothen that, or you do a refilling, and then you ask the patient to come back after about 10 to 14 days. So if you have done some intervention and still the lesion is not improving after 10 to 14 days, again, that should raise your suspicions that what you are possibly dealing with is something malignant. So the concept of follow-up here is very, very important. So I'm going to show you a couple of pictures now, but first let's come to what are the characteristics which should further increase your index of suspicion for such cases. So if you gently manipulate that lesion, usually that lesion might start to bleed, number one. The duration of the lesion should be more than 2 weeks, all right? It is usually reddish in color or reddish white in color. It is fixed to the surrounding structures. It usually has a rapid growth rate. Patients will typically give you histories of a couple of months or maybe even 20 to 30 days. An oral cancer patient usually will not give you a history of years, that I've had this for a last a year or two. Usually the history is a lot shorter. The growth rate is, like I said, it's usually quite rapid. It shows induration, and typically it presents like an ulcer. Now, in not all of the cases, but it may usually presents like an ulcer. So I'm going to show you a couple of pictures, and the reason I show you a couple of pictures, in fact, let's keep it a bit interactive. How many of you have actually seen a patient of oral cancer? Anybody, raise your hands or just say yes in the chat box that yes, you've seen a patient of oral cancer in your house job, in your undergraduate years, or you've maybe assisted a TMO in taking such a biopsy for such a case, or you've maybe gone with one of your consultants to their operation theaters, and you may have assisted the case with them. Anybody? We have 6, 7 people who are saying yes. One of post-op. All right. So we have, excluding us hosts, I think we have about 30 people here. So 6 people are saying they've seen a case. So that will bring me to my question, that if only 1 in 5 people over here who are attending this webinar have seen oral cancer, how do you think the rest of the people will recognize oral cancer? Because who have seen oral cancer, they might recognize this if a future case came to them in their practice. But the rest of you who have never seen an oral cancer case, how would you recognize that what you're seeing is oral cancer? So this is a big part of why us dentists usually don't recognize oral cancer right away, because a lot of us have not seen such cases. So I'm going to be sharing some real life patient pictures with you to help you recognize what an oral cancerous lesion can look like. So this is a lesion on the right lateral border of the tongue. As you can see, it's quite a big lesion. So I just showed you a couple of characteristics of what a malignant lesion can potentially look like. So would anybody like to tell me in the chat box, how many of those features can you see in this patient? Anybody? There was bleeding, there was ulceration, there was a rapid growth rate, reddish whitish appearance, induration. These were 5, 6 parameters that I just told you. So how many of those can you see in this case? Excessive redness. All right. Induration is usually not seen. That usually feel on palpation. So yes, you are seeing erythroplakia, you're seeing reddish lesion, induration, erythema. Yes, you're seeing basically an ulcer. So this is how an ulcerated lesion looks like. Yes, lesion looks thick. Yes, so that can be a sign, yes, that there can be fixation to the surrounding structures, but usually induration is felt by palpating the lesion. So you potentially saw at least 3 characteristics which are meeting the criteria for what I just shared with you. All right. So let's do another picture. So I want कि ये concepts जो हैं I want कि आप लोगों के ज़हन में properly वो हो जाएं, बैठ जाएं. So जी, anybody would like to take a shot at this lesion? How many characteristics are you seeing over here? Yes, you are seeing a lot of keratin. So reddish whitish appearance. मतलब इसमें आपको नजर आ रही है. Yes, you're seeing keratosis. Anything else? Potentially bleeding. Yes, this portion is ulcerated and you are seeing some reddish spots over here. So it could be a sign of bleeding. Yes. So anybody else? Yes, teeth will be probably loose because again, that's not a sign of malignancy for sure. But yes, in malignant cases, you do come across teeth which can spontaneously exfoliate. In fact, a lot of patients who come to you who may have a potentially malignant lesion will actually tell you that I extracted a tooth and after that I developed cancer. And what they're saying is not incorrect, but yeah, I'm just going to give you the context for it. If you extract a tooth which is in the vicinity of an oral cancerous lesion, So once you extract that tooth, what happens is you are basically disturbing the sort of the capsule of that cancer. So once you disturb that capsule, what happens is that it sort of aggravates the lesion and it starts to grow rapidly then. So what the patient is telling you, it's not wrong, but basically here, extraction here is not the source of the cancer. It is basically, the extraction has basically triggered excessive or rapid overgrowth in the lesion. So this is one thing that a patient history might tell you sometimes. Yes, the spot may be hard or lumpy, so good. You've picked up quite a few points over here. All right, what about this one? The reason I'm showing you all these different pictures and different types of the presentation is that even if you don't come across such a case in your real life, you should have at least seen how a real cancer patient looks like, so you can diagnose it and promptly treat it then. All right, so there are still a couple of more pictures to go. So I hope you all guys keep trying to see which lesion, what characteristics can you find in each picture. White and red patches might have difficulty swallowing, keratosis, ulceration. Yes, exactly. Very nice. So in case you see over here, usually the induration that we see, that is usually found on this portion over here, जहाँ फिलहाल मेरा cursor जो है वो जा रहा है. In fact, you might even able be to see a couple of silk stitches over here. So this is a post-op case in which we've taken an incisional biopsy for this patient, so we can confirm the diagnosis of oral cancer, and then we're going to wait and see what the biopsy report comes. Right, so we have an interesting question over here, but there is a cause associated like extraction or caries, how we suspect it's oral cancer. Like I said, that caries do not cause oral cancer by themselves. However, a sharp tooth can potentially continuously irritate a part of the oral mucosa, and that can cause the mutation in the P450 cytochromes. So that can lead to the development of oral cancer. And extraction by itself does not cause oral cancer, but if you extracted a tooth in the close vicinity of a cancerous lesion, that can potentially increase the amount of, or it can potentially explode the growth of the cancerous lesion. I hope I've answered that question for you. All right. Now, this is also an appearance of oral cancer. Would anybody like to take a shot at this one? What features of malignancy do you potentially see in this patient? Excessive growing, cauliflower-like appearance. Yes, looks lumpy. I won't use that word if as a future doctor, inshallah. But just for description purposes, lumpy is a good enough word. So you have reddish whitish appearance over here. You have some white spots over here, and overall the lesion is quite red. There was some ulceration over here, but again, we could not get a decent retraction done. So we could take a picture of that ulcerated part, but the reason I shared this picture was that not all oral cancer will present as an ulcer. So it can potentially present like such a growth as well. And again, based on its appearance, you should have a high index of suspicion that this could be potentially malignant. All right. So this is another case. In this, you have the classical presentation of oral cancer, in which you have a central necrosed area, or which is basically the ulcerated area. And on the periphery, if you pay close attention over here, you can see some of that reddish whitish appearance over here and some reddish whitish appearance over here as well. So this is on the ventral surface of the tongue. So by showing you all these pictures, I hope that I've actually somewhat broadened your vision of what oral cancer can potentially look like. So now is the time to think that what can we do about this? So I don't know if any of you have watched this Netflix show, New Amsterdam. It's quite a decent show. And in this character, Dr. Max Goodwin, he's basically the director of the hospital. Now, the good thing that I like about him and his approach to being a director of the hospital is that he knows that he doesn't know everything. So whenever his staff members come to him with a problem, he just doesn't, share his knowledge regardless, or just give orders regardless of the fact that if he knows anything or doesn't know anything about how to potentially solve that problem. So the first thing that he always says to the person who brings him a problem is, how can I help? So here you should be thinking about how can we help to decrease the burden of oral cancer in our setting, like at our level, what can you potentially do? So the first thing that you should be all doing is to keep on doing what you are doing. आप लोग अभी क्या कर रहे हो? All of you are sitting on your laptops and you are attending a meeting on how to raise awareness about oral cancer. So taking the first step about making yourself aware about oral cancer is a very big and a very important step, and I commend you all for it, that you've taken time out, especially on a Sunday, and especially when, I don't know about the weather over in other cities, but we have a very nice chilly evening here going on in Peshawar, quite cloudy. Very nice for just cozying up to the heater and having hot chai while you're doing it. But this is the first step. So you keep on doing what you're doing, taking part in oral cancer awareness campaigns online, or taking part in them physically, face to face, doing these meetings, raising these campaigns, doing these walks on any platform that you find suitable for yourself. This is the first big step that you can do. Once you are aware, and you can then potentially create awareness amongst other colleagues, your friends, or in the wider community itself. Coming next, what is the next step you can do? The next step you can do is that you should all try to make a habit of doing a comprehensive intraoral examination for every patient, regardless of the fact that whether they give you a positive history of addiction of tobacco, pan, naswar, or any other substances which I've already showed to you. The problem is that unfortunately, all of us are conditioned to just focus on the tooth, whatever the complaint that patient has given to us, and we don't do a lot of preventative dentistry in our private practices or in our hospital jobs. So I think even if one person starts to do it, and even if one life can be saved, I think that's a huge difference. And you guys should not underestimate the effects of doing this process routinely. Like I said, even saving one life is a huge matter. So what are the areas you should be focusing on while doing a comprehensive intraoral examination? So earlier in a couple of slides before, I told you that there are certain high-risk sites for oral cancer. These sites may not be present in every patient, but if you see a lesion over here, usually these sites are associated with quite a poor prognosis, because these lesions usually develop directly into stage 3 or a stage 4 lesion. So diagnosing them at an earlier junction is absolutely critical. So what are those lesion areas? I'll highlight those again. Number one is the lateral border of your tongue. Then immediately adjacent to that area is your whole floor of the mouth, and this retromolar area over here, the area posterior to your third molars. So these are the areas which tend to develop the advanced stage of the disease quite quickly, and it's important that you specifically screen these areas. So how will you do a comprehensive intraoral examination? So I'll just share a small video here with you, and we'll go through that.
Evaluate the lip area and labial commissures. Visually check the maxillary and mandibular, anterior and posterior vestibular areas. This is a great time to check each of the frenum and attached gingival areas. Visually assess the buccal and labial mucosa. Then palpate digitally the labial mucosa, and then bimanually palpate the buccal mucosa using the middle and ring finger so as not to smear the saliva across the cheek. Examine the structures on the ventral tongue and floor of the mouth. Examine the structures on the dorsal tongue check the maxillary tuberosities and retromolar pads as well. Then have the patient protrude the tongue and digitally palpate the tongue. Then reach far back under the tongue and bimanually palpate the left and right side. Once again, using the middle and ring finger under the mandible as not to smear saliva. You can test the function of the submandibular gland by wiping the Wharton's duct with gauze and compressing.
All right. So basically, this is how you do a quick and a comprehensive intraoral examination. And this is just for soft tissues, because your oral cancer is not going to arise from a tooth. It's going to arise from the mucosa surrounding the tooth and the rest of the mucosa of the oral cavity. So this was a short video. It took all of maybe 30-40 seconds. So this is all it takes to do a comprehensive intraoral examination. It's not like I'm telling you to spend an hour checking the oral cavity for such lesions. You can quickly do it within a minute. So it does not take a lot of time. But the important thing is that you make or develop the habit to do this routinely, and especially for those patients who do give you a positive history of smoking cigarettes or using any form of smokeless tobacco like pan, gutka, and naswar. All right. In addition to this, another thing that you can do is you teach the patient how to do self-examination. Now, whenever Breast Cancer Awareness Month arrives, you might have seen it on various billboards as well as TV advertisements that they routinely tell women to at least examine themselves once a month, I think. Please correct me if I'm wrong. So if they can do that for breast cancer, which is the most common cancer over here. So I think we should also do the same for the second most common cancer in the entire country, and which is ironically is also the most common cancer in males. So teaching males to do their own self-examination is important. So this is something that they can do while standing in front of a mirror. You can tell them to do this at least maybe once a month. So you start off by telling them to just look at themselves in the mirror, look at any signs of swelling, facial asymmetry, any ulcers, any areas of redness, or any lesion that they find on their face, which has been present for maybe 2 weeks or more. Then you tell them to palpate the area adjacent to their mandible just to check for any lymph nodes over here. In addition to this, you tell them, you should show them their anterior border of the sternocleidomastoid muscle. Excuse me. So because we have sometimes lymph nodes are palpable or lymphatic spread can occur directly in this area. So just to check if they feel any sort of a swelling in this area or not, and they have to do this obviously bilaterally. After that, they should check their lower lip. So starting from the dry lip all the way till the alveolar mucosa surrounding the teeth, they should note for any signs of redness, any ulcer, any sore that has been present for a long period of time. So once you've done the lower lip, then you go to the upper lip and make similar observations over here. Then you run your fingers across the alveolar mucosa on both sides just to check for any lumps or sores over there. After that, you check the buccal mucosa on both sides for any redness and similar symptoms over here. So first on the right side, then on the left side. After that, you check your tongue, the dorsal surface, and then you raise your tongue, tell the patient to touch the palate and check the ventral surface. Then run your finger in the floor of the mouth to check for any swellings or ulcers over there. And then finally, as much as they can see their palate in the mirror, so they should check for any sore or anything like that over there as well. Now, finally, another thing that you can do, and I think this is very pertinent because some medical educationists have done studies on the fact that when we are producing a dental graduate, we are just focused on one thing when it comes to oral and maxillofacial surgery, and that is that you should be able to take out a tooth. Now, given the burden of cancer and the fact that oral cancer specialists or a maxillofacial surgeon are not present in every nook and corner of the country, most of the cancer surgeons or most of the maxillofacial surgeons are present in the most of the provincial capitals or the big cities of the province. So you will come across a lot of patients who have I'll give you an example. A lot of patients who come to me privately are sometimes from Afghanistan, from Waziristan, very far-flung areas. So you can imagine that if there is no dentist over there and the patient who has such a sore, do you think how much time it will just take them to come all the way from Waziristan to over here? It takes them a couple of days at least. And it's not something that they're readily able to go and to a doctor in the provincial capital or any of the big cities in the province, because obviously they have to look for someone. It costs a lot of money. It's traveling from one part of the province to the other, especially for the lower class of our population. So I think it's very important that in addition to teaching you all about extractions and impactions and whatnot, that we should be telling you how to take biopsies for such patients at the very least. So this year, Alhamdulillah, we were successful in this, that the modular system for final year BDS was started in where I work in Sardar Begum Dental College, and we have now a fully functional skill lab. So one of the practicals that I added to the skill lab was that I will teach my patients, my students, how to take biopsies. And we did one exercise on the first batch, and they were quite receptive to it. And Alhamdulillah, they managed to do it quite well. So it is our plan that we have started this, and I hope that people who are over here in other different colleges, belonging to different colleges of the country, you guys also make it a point that if you guys have a skill lab, you go and talk to your head of department of oral surgery, maxillofacial surgery, and you tell them, sir, that this thing has started in some colleges of Pakistan, and we should also be trying to do this to help decrease the burden of oral cancer and ensure a timely diagnosis for our patients. So in addition to this, even if let's suppose such a facility is not available in your colleges, there are a couple of centers in Islamabad who do offer courses on minor oral surgery, and usually one of the topics that they do teach is how to take biopsies. So I would strongly advise all of you that those who were not able to do this as a part of their undergraduate curriculum, that they should register for such workshops and learn how to take biopsies themselves. And the money that you've invested in these workshops, trust me, it is one of the highest forms of Sadaqah Jariyah that you can give for your patients. This money is not wasted. Even if you do one biopsy a year, it is not wasted. And it is just pure, in my opinion, pure sawab for you. So be proactive in these things, learn how to do such skills, expand your skills. Because if you are doing courses like C ortho and C endo and whatnot in your house job or after your house job, so I think this is something very critical for you guys to learn as well. So lastly, we have some areas, some universities who have started tobacco control programs. So I think being preventative dentists or those who are working in community dentistry programs, I think it's high time that we should start having a tobacco control cell where we are addressing at least tobacco control amongst our patients who come to our dental hospitals. So I think that should be a core component of the community dentistry programs that are running throughout the country, and they should not just be focusing on caries control and periodontal diseases control. I think oral cancer should also be a focal point and focus subject for them to teach as well. So some countries are offering such facilities like the Aga Khan Hospital. They do have a tobacco control clinic where they're offering a quit to win program. Similarly, another program in I think this diabetes center is in Punjab. So they have centers in Sahiwal, Islamabad, Rawalpindi, I think Lahore as well. So you should know about these clinics. You should know where they are. And if you have such a patient, you should refer them to such clinics if you cannot offer oral tobacco cessation service yourself at your hospital or in your private clinic. All right, so thank you very much. I would warmly welcome any questions, and I hope that the number the question, the better it is. So if we have any questions, let's take them now. Can I suggest some institute to do workshops? I'm sorry, I'm forgetting which institutes offered such workshops. But if I remember correctly, it was some institute in Pindi or Islamabad. I'm sorry, I'm not remembering the name correctly. But they usually do advertise their courses. So I think if you keep checking dental news or some other workshop, some other WhatsApp group that you're a part of, so they usually advertise their courses in such groups. So hopefully uh, you can then register for those. They don't do them very frequently. I've only seen them do it maybe once a year. But I think these is something you should focus on. So how many cases of oral lesions do you get in SBDC on daily? Are you asking about oral cancer or just generally oral lesions? Okay, oral cancer. Oral cancer, I would say that probably in SBDC, not very frequently, maybe once a month or maybe twice a month. When I was in KCD, when I was doing my residency training, at that point, we used to have, I think, maybe 1 or 2 cases a week. Because the problem is obviously in a private institute, you do charge patients for doing biopsies. And over there, we used to have very minimal charges for biopsy. Or in most cases, we would, in fact, make such treatments free for such patients because the patient used to be quite poor. They hardly had money for their fare, travel fare. So like, for example, if you do a biopsy and you're sending it, like we send our biopsy cases to Shaukat Khanum, they charge, I think, around about 7 to 10,000 for a biopsy, and they take about, I think, 10 days to give you a biopsy report. So that is a huge issue that, doing a biopsy is also quite challenging for such patients. Most of the time they take the specimen, then they don't do the biopsy because they said we didn't have the money to do that. So these are some practical problems over here. Okay, next question we have: what are the possible risk factors that make cancer 2 times in males and females? Well, Ibad, the most common reason that I can tell you is the rate of consumption of tobacco and Naswar amongst males. So the more environmental exposure that you have, the higher the chances are that you will develop a mutation in the cytochrome P450 system. So I'm sure you would have noted in your whenever you take a history of a patient that a lot of the times the male patient will tell you about a history of addiction to such substances, but a female usually doesn't. So I think that will give you a good idea that it's the environmental risk factors that they are basically exposed to more. Please share a video of taking biopsy of a patient. I will try to do that. Hopefully next time I'm doing such a case, or I think you should be able to come across such videos on YouTube. In fact, if I see a good video, Dr. Meena, please do remind me. I'll share a video of this with you. So if there's a WhatsApp group of all the registered participants, you can just share it over there.
All right, sir, I'll do that.
Okay, can I please repeat where I was sharing the ignorance table till the patient with erythroplaky tongue? I'll share the presentation with Rumina. So if she can share it with you guys, so you guys can go through all the stuff that I've mentioned over there. So hopefully that should not be too much of a problem. All right. अच्छा, next क्या है हमारे पास? Can we rule out other conditions by only clinical examination? No, you can have a good high index of clinical suspicion based on clinical examination, but the point is that, no hospital, no oncologist will ever treat a case just based on clinical examination or your clinical suspicion. So you always have to take a biopsy of such a patient. So that is a must. You can't escape the biopsy. Like, I'll give you an example. When we used to send patients to Shaukat Khanum for their cancer treatments, so they only accept biopsy reports which have been reported by their own histopathology department. They don't recognize biopsy reports from any other center. So if you are planning on doing a biopsy of such a patient and taking them to and referring them to Shaukat Khanum later on, so you should definitely then send that biopsy report to the Shaukat Khanum lab only. Otherwise, it's just going to be a double expense for the patient. And obviously, there will be an additional 7 to 10 days delay in getting that diagnosis as well. So you're just prolonging the inevitable for the patient and giving the cancer more time to grow. Can breast cancer also cause oral cancer, or can it spread to oral cavity? Very nice question. Not to my knowledge, but breast cancer can metastasize. Have you ever heard of the term metastasis? If you guys have ever heard of the term metastasis, so metastasis is when a cancer spreads from its original location to another location, like to a distant part of the body. So yes, it is possible that you can have a metastasis of the breast to the oral cavity, although I'll have to check the statistics, but breast cancer usually does not involve the oral cavity. It spreads to the brain, bones, I think the lungs, kidneys, those areas more commonly than the oral cavity. Sir, I think at least 1 day per week per month should be designated to free screening of patients of detection of oral cancer. I disagree. I think you should be doing this every day, because this screening, like I just showed you, it hardly takes 30 to 40 seconds. It does not take a lot of time. So if you have patients who are giving you a history of tobacco use, you should be screening them right there and then. You should not make it once in a week or once in a month. That is, for me, is too infrequent, and you might miss a lot of patients with that approach. Patients are not compliant or can't afford biopsies. What are we to do then? Again, a very good question. In cases your patients are not compliant, I would always suggest that you talk to the patient's attendants at that time, because a lot of your patients will be aged patients. They'll be quite old. They might not be willing to go through the treatment. So what you can do is talk to their attendants. Usually they are accompanied by their brothers, sisters, sons and daughters. So you should be talking to them and trying to convince them to do the biopsy. However, I would suggest one thing, that it is ultimately the patient's own choice whether they want to go through the treatment or not. So you can't impose the treatment, you can only inform them. All right. Second of all, if they can't afford biopsies, well, you don't, let's suppose a patient can't afford Shaukat Khanum's biopsies. So you can do one of two things, what we used to do. Number one, we used to have a Zakat fund in our hospitals. So if we had such a patient, what we used to do is that we used to talk to someone in the Shaukat Khanum lab or whichever lab we used to send the patient. And we used to tell them that this patient is going to come for you. We are going to pay for their biopsies because we have the fund, and you just do the needful. You just do the histopathology report and send it to us. So one thing is that what you can do. Second of all, a lot of people are currently doing researches on oral cancer. So they have sort of, you can say those researchers are paying for biopsies out of their own pockets, or they are subsidizing the biopsy rates in their own private labs. So that is another alternative you can do. Like here in Peshawar, we have Peshawar Medical College. They have a histopathology lab. So if the patient is Zakat eligible or cannot afford, so we usually tell someone over there if it's possible to subsidize their biopsy rates. So you should be aware of which centers are giving you what rates for doing a biopsy. So hopefully that should help. Among the following areas, the tongue is the most common site. No, tongue is not, I won't say is the most common site, but yeah, probably amongst the most common sites. Usually we've seen more of buccal mucosa cancers over here, because that is the site where they usually put the naswar or the pan in. So I think buccal mucosa cancer is relatively more common over here, but I have to check this with the literature. What do the studies say? I'm just talking about my own personal experience over here. Are there any support services available for cancer survivors in Peshawar? Unfortunately, I do not know anything about that. I'll have to look this up because right now we have very limited cancer treatment facilities. So I don't know if there are any support services available in Peshawar. To my knowledge, there are none, but I may be wrong. I'll have to look this up. But a very nice question, because cancer is not just about beating the tumor itself, the psychological burden of it on the patient itself, on the family, the nutrition of such a patient, feeding them, everything. A lot of things get horribly difficult for such patients. So ideally, you should have support services for such cases over there. All right. Yes, spreading of cancer. What are some common challenges or concerns that people with cancer face? How can a doctor cope with them? The first thing that and again, I'll just be sharing my own experience with this about your questions, since I don't have the literature with me about this, that people with oral cancer, usually they do have issues with feeding a lot because of the pain, and because usually the cancerous lesion is so big that usually they cannot occlude their teeth, so they can't really eat properly. For that reason, they have a lot of weight loss. So again, here, if the case is advanced, so a palliative treatment for such cases can be done. But again, a lot of patients cannot afford palliation as well. Like Shaukat Khanum usually does not take, I think, more than does not take stage 4 cases, if I'm remembering it correctly. I think they only take stage 1 or 2 cases, especially for zakat purposes. Other than, I think, paying patients, they might take stage 3 and 4, but for zakat purpose, they don't take more than stage 1 or stage 2 unless they've changed their policy. So palliative treatment is usually done at government hospitals like IRNAM, INOR. IRNAM is in Peshawar, INOR, I think, is in Ahmedabad. So you have similar, these are basically government institutions where they have radiation and nuclear medicine available with them. So these are some services they can avail. However, what I've personally seen is, if especially the patient is old and they do not want to go for treatment, then the patient's attendants themselves say that, sir, we don't want to treat them, and we just want to make them as comfortable as possible. So, and we're just going to take them home. So a lot of times I've had this conversation with patients, their attendants specifically, that it's your right. The patient is obviously someone close and personal to you. I can only give you options. I cannot enforce those options on you. So feeding is predominant. Pain is what a lot of patients do complain about. So if you have good pain management clinics, you do have palliative services available at government hospitals. So this is something that can hopefully help them. Is frequency of oral ulcers a risk factor? No. Oral ulcers, like a patient usually, you might have heard of a condition called aphthous ulcers. So aphthous ulcers do tend to recur, especially if you have an underlying hematological or gastrointestinal problem. So frequency of ulcers is not the issue. It's the appearance of the ulcers, and it is the other habits that you have. Those are basically the risk factor for oral cancer. Right, I think Dr. Sumaya was just elaborating what she was saying. So by 1 day a week, a month, I meant by spreading pamphlets, advertising around underprivileged communities, and free screening. Yes, that's a very good idea. Like, you have a breast cancer awareness month, you should have an oral cancer awareness month as well. And if you can do it more frequently, like I said, this is more under the domain of maybe probably community dentistry or preventative dentistry. So I think if they do that, that would be an excellent thing that they can do. And I think maxillofacial surgeons should also help in such regards, taking part in whichever campaign that they can. What are the chances of recurrence after treatment? What follow-up tests will I need? And how often will I need them? Chances of recurrence depend on a lot of factors. The one factor that I can tell you is based on how good your surgery went, initial surgery went. So if your surgery showed that the tumor that you have excised, you've taken a good healthy chunk of normal tissue with it, so that usually decreases the chances of recurrence. But that is not the only criteria. We do histological grading of the tumor that you're facing. So if you have a poorly differentiated carcinoma, so in that the chances of recurrence are high. If you are being treated in an advanced stage, like in stage 3 or stage 4, so the chances of recurrences are again high. If you're not letting go of the risk factors, a lot of patients sometimes do that once they think the cancer is gone, they start their Naswar and everything once again. So you can have a recurrence again. So follow-up tests are simple. You just need to go to your dentist and to your maxillofacial surgeon, and they usually give you the follow-up protocol. Usually it is predominantly made up of clinical examination, and sometimes a scan might be done, a post-op CT scan or maybe a PET scan. So these are things that are usually decided by the oncologist. So for the first year, usually following treatment, we usually see such patients at least once a month. At least I think for the first year, then every 2 months, I think for the second year, and then so on and so forth. So it depends. This is something your oncologist will discuss with you, and it's usually different for every patient depending on how they were treated and whatnot. All right, so I think I've reached till the end of the chat. If there are any more questions, please let me know. Otherwise, I'll hand over the reins to Rumina.
So I think the question answers are done.
All right, Chale.
Thank you all for joining today and being a part of the insightful webinar. We hope you found today's webinar both enlightening and thought-provoking. We truly appreciate his expertise and dedication to advancing dental education and dental health. I would also like to express my gratitude to Dr. Fahad for sharing his valuable insights and expertise with us on behalf of Pakistan Association of Dental Students. Your passion for dental education and commitment to excellence are truly inspiring. Now we request all of you to turn on your videos so we can take a screenshot. We would also like to extend our appreciation to all the participants for their active engagement and thought-provoking questions. We hope you found this session beneficial and that it sparks future exploration and innovation in dental education, and it encourages you to play a role in raising mouth cancer awareness. Thank you once again for your participation, and we look forward to seeing you in future webinars and events. Thank you, and Allah Hafiz. Now we're going to take everyone can put their videos on, so we'll take a screenshot. If that's okay. Like everyone doesn't have to do it, whoever is comfortable, they can do it. We'll wait for, let's say, 5 minutes, 2 minutes, and then we'll just take a picture if everyone's ready. Wait, let me see. If everyone's ready, we're going to take the screenshot now. Wait 1 second. I'm a little bad at this, so I'm just going to try and take a screenshot. Sir, if you can stop sharing your presentation.
All right, I'll do that.
Wait. 1 second. If someone can like help me right now because I don't know how to take the screenshot. So if one person can help me out with that.
I shall take the screenshot, Ravina.
Okay, that's best. Everyone start posing.
Or who are not opening their cameras, they can choose any reaction feature. So that will be great. I will be taking screenshot on the count of 3. And there are 2 screens, so just hang around. 1, 2, 3.
Mariam, should we take one more?
Wait, only one screen is covered right now. I'm taking another screen.
Okay.
Thank you, everyone.
Thank you. You may now leave the webinar and I'll be sharing the sir's presentation, inshallah. Thank you, sir.
Thank you so much. Sure. Hope to see you guys, and hopefully get to collaborate with you in the future, inshallah. So
Inshallah.
thank you for having me.
Sir.